we will start for just 2 minutes, so the audience will be with us, sir.
Sure.
Just 2 minutes. Thank you for joining us, Dr. Malik, and many thanks to my dear friend, Dr. Muhammad Hashim.
My pleasure. It's always nice to give a talk, but even more exciting to give it to colleagues in different regions.
My name is Muhammad Al-Ashhab. I started online teaching about 5 years ago at the start of COVID era, and still going on. I've made webinars with India, with the UK, of course, with Canada, with Australia, with Brazil, with Germany, with Switzerland. So we are going on, and thanks for the support of our dear speakers from different countries of the world, and of course from Egypt. We are going on.
Oh, that's amazing. I think since the COVID has become quite a nice thing to do, and that's something I'm utilizing as a training program director within the West Midlands, trying to invite the speakers from outside the region to get a little bit more diversity and difference of opinions for everyone to come and share how the other side does things.
Yes. May I introduce you, sir, and Dr. Muhammad Hashim?
Yeah.
Bismillah ar-Rahman ar-Rahim. It's a great honor for me to be with one of the eminent hospitals in UK tonight, the Royal Orthopedic Hospital, Birmingham. Tonight is a very special day. I would like to thank my brother and my friend, Dr. Muhammad Hashim from Frimley Park Hospital, to be the organizer of this webinar. Many thanks, my dear friend, Dr. Muhammad, and I'll let you introduce all our dear guest speakers. Please, sir.
Yeah, so good evening, everyone. So we're starting with a very strong start with Mr. Malik. So Mr. Malik is an eminent shoulder and knee consultant. He's the TBD of the West Midlands Dairy for orthopedics, and he will take us through today ACL reconstruction with soft tissue, and is QT a safe option or not? Please, Mr. Malik.
Thank you. Good evening, everyone. Assalamu alaikum. Thank you for the invitation, and it's a pleasure to give you this talk on a topic that is close to my heart, and something that I have learned from my fellowship after my training, and I'm beginning to do a lot more of it. It's some research that I've done recently with one of my registrars, and I'll share that with you as well. So quad tendon ACL reconstruction is not something very new. It started back in 1979 with Marshall JL, who described the technique. It wasn't until 1984 that Bloth talked about the quad tendon with bone block. And not until 1995 that Fulkerson talked about central quad tendon technique. He then went on to describe outcomes of 29 patients that underwent soft tissue quad tendon ACL reconstruction, of which 2 required revisions. And later on, he described this tendon, quad tendon reconstruction, as reliable, pain-free, low morbidity alternative to ACL reconstruction. So it's not something that is new, but certainly in the last decade or so, it's become, shall we say, more fashionable as the techniques have improved. So quad tendon is much more familiar to us than we actually think. We do knee replacements every day, and quad tendon is something that we divide when we're doing knee replacement, so it's right in front of us. If you're doing trauma, you do quad tendon repair all the time, and it's again right in front of us. So we're much more familiar with quad tendon than sometimes we think. But a boring part of the whole thing is anatomy, but it's quite interesting. It's made up of 3 layers: superficial, middle, and deep. It's quite a long tendon. It can go up to 8 centimeters, and it's got reasonable width of about 3 centimeters. And depth-wise is about 8 millimeter deep, which is almost twice what the BTB gives as an option. Layers. Layer 1 is you have rectus femoris, which blends into with the rest of the tendons as it inserts at the top of the patellar tendon. But there's also a fascial or a bursal layer right at the top, which comes from the lateral to the medial side. And this is something that you will encounter, and I normally peel off with with a gauze just to clear that area to be able to see the actual fascia of the quads tendon. The middle layer is combined with the vastus lateralis and the VMO as it blends in and goes into the patella tendon superior pole. And the last layer, the middle layer, is the vastus intermedius, which is quite parallel. When you look at the biomechanics of it, well, the full thickness quads tendon can be up to 10 millimeters. And when you compare it to BTB, it's almost twice in terms of the load to failure is twice as much as the BTB. And it's significantly higher than the native ACL itself. When we look at the partial or full thickness graft, because it can be used as a partial or full thickness, that there is not much difference between the two. On the top here, we've got the BTB as a comparison, and at the bottom or the middle picture is a graft tendon that I used in a biomechanical study when I was in Canada in fellowship to look at a suture graft construct, load to failure, and it's quite a robust graft. In terms of harvest technique, well, you can either go longitudinally or you can go transverse. But when you're starting off and you want to make sure you're in the middle of the tendon, then it may be a good idea to start with longitudinally. And it just gives you a bit more awareness of where the muscle is. What we don't want to do is go into the muscle, because muscle is no good as a graft. Ideally, you just want to have a 10 millimeter width, and that's very reasonable. You can have slightly less, but you want to aim for 1 because you may end up getting slightly less depending on the technique you use. You can use a freehand graft technique like here, but I'll go through some of the other different instruments that are available in the market. And all you need to do is measure your 1 centimeter from either side, create a bit of railroad from medial and the lateral side. You can use that with a knife, or you can use that with a cautery. Now, this is a technique which takes the bone block, but you don't have to use the bone block. In fact, it's easier to harvest the graft without the bone block, and it's much quicker. But if you have to, then you do what you do with the bone patella tendon bone graft technique, and you take a bit of chunk of the bone with it. Once you've got, and that is roughly about 1 centimeter by 2 centimeter by 1 centimeter bone block that you want. So I've used various instruments in the market, depending on where you are and what you have available. There's Karl Storz, Arthrex, Smith & Nephew have come out with something new. So in this system here with the Karl Storz, there's a blade runner, a separator, and a cutter. It just comes in with one tray, and the blades are packed separately. So this one is a 5 millimeter separator. So this separates the tendon into 5 millimeter thickness. Like I said, you can get it full thickness or partial thickness. What we don't want is a full thickness graft. That can be too bulky, and your tunnels then need to be much bigger. So you want ideally a graft between 8 to 9.5 millimeters. So this separator encourages to make sure you don't end up taking the whole graft, which of course can be quite thick. This is the cutter. Once you've got the graft, and they all, I don't know if you can see my mouse, but they've got numbers on it because you want to get the appropriate length, and it tells you when you're about to cut whether your length is correct or not. So, and this will cut at the proximal end. So I hope this video plays. I know there may be a little bit of lag, but this is a technique that I picked up from Peter McDonald, who is my fellowship director, is an eminent professor in Winnipeg in Canada. And I'll just play a video which is short, and that will help you understand the technique. I hope you can all see it. So just a Lachman test there to show that this is ACL. That's my initial there when I started it. Unfortunately, when I was recording it, the graft technique didn't go according to the plan, as it always is the case when you're recording it. So we went to another patient afterwards. The incision is very small. It's 3.5 centimeter. If you missed it, it's roughly 3.5. In fact, you can do it to a slightly smaller incision. It's a good idea to insert a scope, and it gives you an idea of where the tendon is and where the muscle are. And you can mark it with the pen at the top to make sure you understand where the direction of the graft of the tendon is. What you don't want to do is veer off into the VMO on the vastus lateralis. This is the blade runner or the strip runner that creates the path. And once you've got that, you can snip away with your mats or macindos, and you can start snipping it and clearing it. And you put a tack suture to make sure you pull on it. And what you want is minimum of at least 7 mils. There's different techniques of suspending it, obviously with a suspensory or a suspensory on a screw or suspensory on both sides. You need to attach the suspensory for the femoral side. So this is an adjustable loop system, the button system. This is locking whip stitch technique. So you put a couple through in the proximal end, so you can get a good control on the graft. You take off the tag suture. You then put in your adjustable loop button that will go on the femoral side. And then you secure that again with a couple of throws back and forth. Once you've got that, you take the needle off and you tie the knot. The next step is to cut it from the proximal end. This is a cigar cutter. You push it through, and again, it's got a number on it, and it tells you how long are you cutting. You can see that just about there, and that's your graft. And it's a very it's a beautiful graft. I call it Beauty and the Beast because it's both beautiful and it's a beast of a graft because you can get easily 9 mils. So this is my video of how I harvested. Take the sound off. So this is me putting a camera in, as I was showing you earlier, and I can figure out where my VMO is. And just to show you again, the numbers are there, so you know the length of the graft you're about to take. This will create a path. This is a 10 mil, so we're getting a 10 mil width graft, and it creates these railroads or the train tracks on either side, and you make sure that VMO is on this side and the vastus lateralis on this side, and you're just dead center within the quads tendon graft. Once you've got those railroads, you're going to go through once or twice back and forth, so you make sure you've got through the layers. What you don't want to do is come short. So the next thing is to use a separator. So this is a 5 mil separator that I showed you, and all you do is try to get the 5 mil of the graft. There's a bit of technique to that because you don't want it to go too deep. You don't want to go too superficial. If it's too deep, it's too thick. You don't want to be too greedy. And again, you run this across so you can get that 5 mils layer separated from the rest of it. And you can see the marking there. You want to get up to 70 mils. That's the technique that I use, which is suspensory. And this is the cutter now. So once you've got that, it will go in. And again, it's got marking on it, and you want to make sure you don't want to come short, because once you come short, you can't really do much. So you got the 70 mark there. That's a 70 mil graft. And just make sure you've got everything in the cutter. And again, you can put a camera in if you want to, starting off, to make sure you're cutting the graft correctly. And then you pull that out, and that's your graft. So that's the harvest technique that I've used. It's 1 finger breadth above, and it's about 2 to 3 centimeters. So now you're going to close the fascial defect as well. It depends. If you go through all the layers, then the fluid will leak out. If you haven't, there's some evidence to say that you don't need to close the defect. I'm not sure if it's the same video, so let me just play. Okay, this is the one. So this is me closing. It's called shoelace technique. You may have come across First Pass Mini from Smith & Nephew, or the competitors Scorpion. You may have come across something like that, which if you do rotator cuff repair, that is, that's the way I close this technique. It allows you to use smaller incision, but you can also go quite proximal. And all it does is shoelace technique, back and forth like shoelace. And at the end, you can just tie it off. Obviously, it's easier if you're doing a longitudinal incision and you can close direct under vision, but here it can be a little bit challenging. So, but it's easier using that technique. Okay, so at the end, what you get is a beautiful graft, which is about 70 centimeters. Like I said, that's the graft technique that I use, in which I do suspensory on both sides. So on this picture, which I hope you can see with my arrow, this is the femoral endo button, and this is adjustable on the tibial side. After the graft is inserted, this is how it looks. So you got PCL on this side, and this is the quad tendon ACL. And this is a video of just to show you how it looks on the inside. Again, it's a very, very good graft. Okay. So now, what are the pros and cons of it? Well, the pros are that it gives you a large cross-sectional area. You can use a split or a full thickness graft if you wanted to. You can use it with or without the bone block. It does have a lower donor side morbidity and low re-rupture rate. And it also has 20% more collagen. So there's everything to like about it. What about the cons? Well, if you have not used to doing this, then there's a bit of a high learning curve. Well, I think I may disagree to that, because I think that is more true if you have to take a bone block. As a soft tissue graft, it's not that challenging and not that hard. Obviously, if you're taking the bone block, then there's always risk of patellar fracture, as is the case with bone patellar bone. You can have a shorter graft, which you don't want, but again, with the recent techniques of suspensory techniques, then shorter grafts of even 6 mils, you can get away with it. You just got to make sure your tunnels are well measured. There's some debate about there's extension strength loss or a quad weakness, but I'll go through some of the evidence through now. So here's a study that Mo Khalifa, who was my registrar at the time, who's just about to finish his training here in the West Midlands, presented at the East Coast last year in Boston, which was very well received. And we looked at the clinical outcomes of the soft tissue quad tendon graft. Now, most of the studies that you'll come across and read will have a mixed population, because earlier techniques were the graft was harvested with a bone block. But most, in fact, to my knowledge, and when we did this review, we didn't come across any review that separated the soft tissue from the bone block. So we purely wanted to look at the soft tissue autografts. So the aim was to look at the functional outcomes and the complication profile. So studies, there were 18 studies, 3 randomized controlled trials, 4 case series, 8 retrospective case controls, and 3 prospective. We had over 2,000 patients, or just under 1,200 were quad tendon, and about 500 were hamstring, and a small portion were BTB graft. Majority of the patients were male, and average age was 26 with almost 2-year follow-up. Now, when we look at the quad tendon versus hamstring studies, we found there to be no significant difference. When you look at the quad tendon with BTB, again, there was no significant difference. In both of these studies, in both these comparisons, one of the studies, there was high Lasham score at 6 months, but not maintained at 1 year. Again, for the quad tendon versus BTB, the authors, Letter et al., found that high Lasham score for quad tendon patients. And when we looked at the quad tendon only cases, they were excellent IKD scores. So this is a meta-analysis, BTB being the gold standards when it comes to ACL reconstruction. There was no difference in the studies that we had all the data available. Now, when we look at other parameters like return to sports, well, there was no significant difference in return to sports. Quad tendon does not provide, however, more rapid recovery, but there was less harvest site pain compared to hamstrings. We talk about analgesic requirements. In one RCT showed less pain and analgesic consumption in the immediate post-op period with quads versus hamstring. Well, what about complications? Because ultimately that's what we look at. Well, the quad tendon gave about 8.2% complication with about 3.5% graft failure rate. Reoperation was 8.1%, and that's majority was for cyclope lesions. I think one part of the reason is that the graft is so big. If you're not careful, then you can get that scar tissue at the front. How do these measure against other grafts? Well, with quad tendon versus hamstring, there was no significant difference in the graft failure, and anterior knee and kneeling pain, there was no difference when you compare hamstring and quad tendon. When you compare quads with BTB, there was no significant difference for stiffness, instability, or graft failure. However, anterior knee pain, not surprisingly, was less with quad tendon. Look at that, 4.5% versus 26% in BTB group. And again, anterior numbness was 1.5 versus 53%. And again, that's because there's a large incision right off the front of the knee. And we know that with knee replacement, there's a problem with the numbness and anterior knee pain, or not knee pain as such, but the pain with kneeling. So quads is quite good in comparison to BTB in these two regards. How do we measure with our current study with the others? Well, we compared to the previous systematic reviews and meta-analysis, but just a word of caution that all these previous ones had a mixed population. So soft tissue as well as the BTB, soft tissue as well as the bone block quad tendon. So graft failure rate was comparable. Infection was very low with quad tendon. Anterior knee pain, again, very low. Kneeling pain, very low. And donor side morbidity was very low as well. And we define morbidity as tenderness, numbness, pain, or irritation at the donor site. So from our review, we concluded that ACL with soft tissue autograft in adult population has low complication rate, less anterior pain and numbness versus BTB. And there's no significant difference in PROMs. But there's a need to have some higher level of evidence studies like RCT, specifically looking at these things in larger numbers, of course. So just to finish off with, this is the paper that has recently been published from this review that we did. It's out this month in OTSR. I'll provide a link, hopefully in the chat, and you can download a copy for free if you wish to. I hope that was useful. Thanks very much for listening, and I'll be happy to answer any questions should anyone have any.
Thank you so much, Mr. Malik. It was really, really informative. And yeah, I think, yeah, all the colleagues there in Egypt and the Middle East will take a message from this and start using more quad. I think our next, so we'll keep the chat on. So if there's any questions, can post on the chat and we'll get all the questions answered at the end.
Sure.
Yeah. Thanks, Mr. Malik.
Thank you.
Yeah, our next speaker is Mr. Boudair. So Mr. Boudair is a foot and ankle consultant, Royal Orthopedics. He has special interest in diabetic foot stuff, in trauma, and MIS, and it's a great pleasure to have him with us today. He will be speaking about acute foot attack and Charcot foot. Mr. Boudair, please.
Thank you very much, and hello, everyone. Thank you for the invite. Shall I just share? How do I share my screen? Just go there. Cool. My screen. Okay. Can you see my screen?
Yeah, we do.
Sure. So thank you for the invite. I'm just going to try and cover two very, very important topics really when it comes to foot and ankle that I believe everyone should know at least the principles of how to manage. And I'm just going to go through them quickly, try and cover as much as I can with the time allocated. So, but if there's any questions, please do stop me. If you see a QR code, that's probably the evidence where I got my information from. So feel free to scan it, and you'll have that for you to read. So when it comes to orthopedic in general, so there is actually very, very few emergencies if you count compartment syndrome, and then you have hip dislocations, etc. One of them, I think one of the most important ones, would be the acute foot attack. And this mostly affects people with diabetic neuropathy, but any other neuropathy as well. So what is it? It's basically has been given the new name attack, just to give the people and alert people to the severity and the urgency of this situation. So it's an acute condition that affects the foot, and if not managed and treated promptly and appropriately, the patient might end up losing their limb or their life. And it causes an inflammation of the foot. It's rapidly progressive. It damages skin and tissue. And as we mentioned, it needs to be managed promptly. So why does it happen? Most common cause is infection. These patients are neuropathic, immunocompromised. They don't normally, we'll talk about this in details in a minute, they don't normally show the classical signs of infection and sepsis in the early stages, and it just progresses. The next one is vascular. If you have an acute ischemic event, that also counted as a foot attack. And lately, the deformity, mainly the Charcot neuropathy, has also been added as an acute foot attack, because it also leads to skin breakage, infection, and possible amputation. So how do you diagnose it? First, was this systematic? As we're going to mainly focus on the infectious side of things. So most people with infection will present with high temperature. That's not the case in 50%, and some papers even report it's not even in 80% of patients. So 80% of patients might come to you, they look normal, they look okay, normal temperature, they're not tachycardic. But what you mainly see is the foot itself is swollen, red, sometimes discharging of pus, and sometimes you feel crepitus. And this is all alarming. You need to do a proper vascular assessment if you are able to. You assess the standard stuff. You try and feel the pulses, capillary refill time, and if you have any Doppler available to you, that would be good. When it comes to doing bloods, most patients, again, especially in the early stages with neuropathy, they will have more or less normal white cell count. CRP has not been found to be helpful unless it's significantly higher than 150 or 200. The most kind of specific one is ESR, but it needs to be very high, more than 70. And if it's more than 70, that probably gives you an indication that's more of a deep infection and osteomyelitis. Of course, you need to look at the HbA1c, make sure it's not too high, and if it is, you need to manage it. And then if you have time, then it is always advisable to get an X-ray and an MRI scan, but that should not delay your management. Most of the times in most hospitals, you can't just wheel the patient straight to A&E. There's a bit of a wait until you get the space and theatre, etc. So if you have the chance or the availability to get a CT, an X-ray and an MRI scan, it does help with your management, but it should not, again, delay your surgery. Microbiology, as with any sepsis, ideally you want to get a biopsy or a sample before you start antibiotics. So if the patient is stable clinically and you think you'll be able to take the patient to theatre in time, you wait, and when you take them to theatre, you take your deep tissue samples from the bone. But if not, and if the patient is septic, what you need to try and do is get deep wound swab. So you basically stick that wound swab all the way deep to the bone. Superficial wound swabs are useless. And some studies found that this is actually can correlate up to 60 or 70% of what the bone biopsies are. At least you've got something better than nothing. So do that and then start the antibiotics promptly if the patient is septic. So how do we manage it? Getting it right first time. So you need to identify it quickly. This needs to be managed by a team. So it needs to be the surgeon, the staff in A&E. You need a medic to stabilize the patient, especially if they have a high BMI, septic, or in shock, maybe an anesthetist as well. You also need the microbiologist. And time is tissue. The sooner you take them to theatre, the better. And the longer you wait, the more likely to lose the limb, or even worse with sepsis, lose the life. This is highlighted, and now in the UK, with the recommendation of both us and NICE guidelines, even surgeons in the early stages of the training, they need to be able to recognize this and do a safe incision and drainage as an emergency. The way you manage it, in the initial stage, you admit them, you follow a local sepsis protocol. We talked about the antibiotics. You only start them after you take samples, unless the patient is septic. If you can get imaging, great. Or if you can get arterial Dopplers, that would be fantastic, but do not delay going to theatre. Once you've taken him to theatre, you try and debride all the necrotic and infected tissue. We'll talk about that in more details in a second. You wash it out thoroughly, and then you apply dressing. You take him back to the ward with the plan to come back and have a second look in 48 to 72 hours. And if you haven't done a proper arterial investigation, that will be the time to do it. And then the phase 3 is basically the wound management. You keep them non-whip bearing and offload the limb until the wounds have healed. You check the wound regularly on the ward. You can wash it, debride it. Most of these patients are neuropathic, so they don't feel it, so you can continue the debridement on the ward. If needs be, you have to take them to theatre back again, do that, and a lot of patients will require vacuum dressing. At that time, use that time to assess, if you haven't done the rest of your investigations, radiology, vascular assessment. Hopefully by then you would have had the results of the microbiology samples back, so you can give them targeted antibiotics. And it's an MDT approach. If the skin closes, happy days. If not, then you need to liaise with your plastics colleagues whether a skin graft is appropriate, or sometimes even free flaps in selective cases. And you discharge them to an appropriate MDT team to look after them in the community. When you take them to theatre, you should follow the green, amber, the red, amber, green zone. So the red zone is basically debride anything that grossly looks infected. And then after that, when you clean it, we all get to that layer of tissue where you think, well, is that infected? Is that dead? Is that alive? And most of the surgeons tend to leave it and give it the benefit of the doubt. Actually, in these conditions, anything that even vaguely looks infected needs to come out on stage 1. And you only stop when you get to the green zone, which is the healthy, bleeding-looking tissue. So, example, this patient coming back with, it seems like 2 sinuses with pus coming out of the heel. You take the patient, you do a thorough debridement, and you can see the wires that basically to try and stabilize the bone. Stabilization is key to achieve eradication of the infection. You can do that with a frame. I'm personally not a fan of frames, and I tend to use wires. So this is the patient in the lower right corner with the wires. You take the samples, you apply a vacuum dressing, and over a few weeks the wound have healed, and thankfully the bone have also healed. So your aim is to save the life of the patient by saving the limb and saving the function. A lot of these patients, the risk of a major amputation in these patients, the comorbid neuropathic patients, is actually higher, the 5-year mortality, than most cancers. So if you look at the major amputation here, which is amputation of a limb, it's only slightly lower than the death rate from lung cancer, but higher than all the other bits. So it is a genuinely life-saving surgery, and this is the same patient going back to his normal function. They all need to be in a protective footwear. They can't, any of them, they can't go back to just normal footwear, and they need regular care. Okay, and you can see that's the foot there healed. So in summary for this bit of the lecture, the main idea is you need prompt diagnosis. You need to be aware that they don't always show the classical signs of sepsis. So you always need to have a high index of suspicion. You need an MDT team, times tissue. You need to take them to theatre promptly, and you need to do proper debridement and follow them up afterwards until the wounds are fully healed, and hopefully save them. Okay, so quick cases. This is a patient coming to A&E. You can see there's a wound there. There was some pus coming from the wound. There's a bit of crepitus. You take him to theatre, and there is pus coming out. And you need to chase it all the way up. You have to open the tendon sheath until you get to a very clean tissue. It doesn't matter how high you need to go. You need to just be brave and do it. And these are the red, amber, and green zones. You do proper debridement until you get to the clean tissue, with appropriate dressing until it's fully clean. And this patient had a skin graft and a small area that was grafted for a second time at the end, and the patient was walking again. This is a very common presentation. You find a patient with a swollen toe, sometimes with an abscess. Again, you need to do thorough debridement. Here we had to do a ray excision, vacuum dressing, and it's all healed, and the patient discharged. Another one, this is an example of the last one, which is the deformity, acute foot attack. This is the bony, this is the head of the talus coming through the skin because of the deformity. Patient developed an infection. That talus was riddled with pus. Patient taken to theatre, and you can see there's another track. This is the bone. The whole of the talus was excised. These are antibiotic-loaded beads, samples sent, and it's stabilized with wires. And over time, with management, the patient has healed. Sometimes you have to go back for a second stabilization with metalwork. We can talk about that in the second lecture. But yeah, this patient was back into his normal footwear. So this is the acute foot attack, very common presentation. Every orthopedic surgeon that deals with emergency should be aware of the principles of managing it. So the second one is the Charcot foot neuropathy, which is the condition that I believe most surgeons, including foot and ankle surgeons, try and run away from. So what is it? So basically the bone collapses and the joints dismantle, and that deformity causes overloading on pinpoint areas in the foot. The skin breaks and you get an infection, acute foot attack, and that all can lead to loss of the limb. So two theories: there's the neurovascular and the neurotraumatic. The neurovascular, you got microvascular disease in the foot that leads to microocclusion, and that microocclusion leads to microinfarcts, and then with a series of microinfarcts creates an inflammatory process which activates the osteoclast, and you get resorption of the bone. Or it's the same neurotraumatic, so you get this micro trauma that again in itself triggers the inflammatory process and osteoclast to start eating on the bone, and then the joints and the bones collapse. And in reality, it's probably a mixture of these two together. It doesn't only affect the foot, it can happen in the shoulder, it can happen in the knee, or even the hip. Patients present with ulcers, infections that more often are very difficult to treat. And we talked about the high mortality rate with these patients if not treated. When they present to you, you need to always make sure you rule out infection, as we discussed in the first talk. Always think about the deformity and neuropathy. You always need to do a vascular assessment, and you always need to think about infection. Any diabetic foot, when it presented to you, these are the three things that you need to go through thoroughly. The way to do that, so neuropathy, you can do the 10-gram monofilament or the 128 hertz tuning fork, and they are reasonably good, but they're not very accurate. You can easily miss early neuropathy. And the most accurate one is if you get a neurothesiometer, which is basically gives a bit of vibration, and you keep toning it up until if you go above 25 volts, if the patients can't feel it until 25 volts, that's diagnostic of neuropathy. And the higher the dose, the worse the neuropathy that you have to give. But again, these are okay. If you don't have the monofilament, what you can do, especially in the emergency department, if you get a pink needle, a pink Venflon cannula, just take the needle from the inside and use the plastic bit that more or less very close to a 10-gram monofilament. You can use that. You can check the temperature. In early stages of Charcot, there's an increased temperature of more than 2 degrees in comparison to the non-affected limb. You do a proper vascular assessment with a Doppler, as we said, or a duplex. And before all of that, you assess the patient clinically. So areas of callosities, these indicate high pressure zones, and these are pre-ulcer. So every ulcer is preceded by a callus. And this is the time that you need to catch it before the ulcer breaks. Okay, so if they presented to you chronically, you need to try best and get a sample to rule out infection. You can get a bone biopsy with these needles, a Jamshidi needle or anything of that sort. You can do that in the clinic. You can be guided by the imaging. If you do an MRI scan, you know where it is, and you can put a needle in there, take a bone biopsy. That also helps. Plan your treatment, whether you do for a single stage or 2-stage. Many classifications, but basically, in summary, what it says, the midfoot is the most one affected, and if you have Charcot and the calcaneum, that's bad news. The stages, the first stage is when you have a bit of erythema, a bit of swelling. You do an X-ray, and the X-ray looks fine. Normally, you pick it up on an MRI scan, and this is the ideal time to pick it up to try and offload. And if treated properly at that stage, the outcome is usually excellent. After that, then with the activation of the osteoclast, you've got the bony debris, the bony formation, the joint starts to collapse, and you get the deformity. This stage lasts anything between 6 and 18 months. And after that, you start to get the calcification, the coalescence. That lasts again for another 6 to 12 months. And at the final stage, you get the consolidation and the reconstruction. At the end of these stages, then what you aim to achieve is to have a stable, chewable foot with no risk for ulceration or infection. So at the end of stage 2 or stage 3, you're going to end up either, if managed properly, with a foot that's stable, with no ulcer. It doesn't matter if it's collapsed, that doesn't make much difference to these patients. As long as you can put them in a shoe with no prominences, no areas of increased loading, and they can mobilize, then that's fine. That's all you need to do, and that will be successful. And usually we do that by putting them in a total contact cast. If at the end you have a deformity, but that deformity is stable, i.e. the foot is consolidated and solid, but you have bony prominences, then you can treat that by shaving those bony prominences as long as the foot is stable. If at the end, the foot, you got a deformity, but the foot is unstable, shaving bone is actually going to make it even more unstable, and you're going to always have areas of high load, ulceration, and infection that you can't control. Yeah, so this is an example of an early stage. A patient come with a swollen foot. You do an X-ray, there's not much to do there, but you do an MRI scan, you can see that classical sign of early Charcot, and a good radiologist should be able to identify that from osteomyelitis. You offload these patients in a total contact cast, and they usually do well. This is the second stage where you have the bony collapse. The third stage, you can see some bony formation and coalescence and calcification, and this is the remodeling in the final stage. The treatment, the gold standard is the total contact cast. Whether you keep them non-wet bearing or full wet bearing, it's there's no evidence one way or the other. Most of these patients are extremely difficult to non-wet bear. They don't feel the foot, and a lot of them are overweight. They have weak upper body, so they can't actually non-weight bear. If you really want to non-weight bear them, you might want to consider using something like a ball iron. Apart from that, in my practice, I usually allow them all to weight bear with a proper total contact casting. At the later stages, you can do something like a crow boot, but these are kind of pre-made and they don't suit everyone. Once, as said, at the end, if it's stable and it's healed, then you can move them into protective custom-made shoes. If they're not, and at the end they come up with these calcifications or areas of high pressure under the foot, you need to catch them before the ulcer breaks, and you need to either assess if the foot is stable, then you can shave the bony prominences, like in this example, and you really need to take all the bone that's below. If you draw a line from the calcaneum all the way to the first metatarsal, you shouldn't have any bone in the midfoot below that line. And sometimes you also have to do tendon Achilles lengthening to offload that. If that's not the case, then you need to do some complex reconstruction. I'll give you a few examples to end up with. This is the same lady that we started with. She's 56, insulin-dependent diabetic, had a total hip replacement. She lost her job because she had ulcers on and off for about 2 to 3 years. She lost her relationship with her partner because she always had a discharging, smelly foot. So she comes to me, we do an X-ray, you can see it's completely collapsed. It was unstable. We do a CT scan, and then the next thing you do a vascular studies. This patient had an angio, and most of the blood vessels were okay. There was small vessel occlusion, but apart from that, they were all patent. So I do 3D printing of most of my Charcot reconstruction. It just makes it easier for me to plan my cuts and save time in theatre and plan what metalwork I need to use. Principles of reconstruction of the Charcot is another talk on its own, but the principles basically, you need to get bony position. You need to use super construct. So a simple nail or a simple plate does not work, and they always tend to fail. So you start by reconstructing the hindfoot, realigning the bone. Then you move on and you take your wedges from the midfoot. You fix the hindfoot with the nail. You move on to fixing the midfoot with new techniques. You can use, these are called bolts and beams. And at the end, you supplement it to help with the rotational stability with more plates. So a lot of metal work there, but anything less than that, you'd probably end up with failure. This is the patient a few weeks after. You keep them non-wet bearing until you get solid union. Sometimes that could take up to 4 to 6 months. Don't rush it. And this is the patient at 3 months, and this is the patient at 1 year. Coming and mobilizing, and you can see you can make a huge difference to these patients, and these patients do heal if you manage their biology, if you give them appropriate antibiotics and you flow it appropriately. You don't always have to do the hindfoot. This patient had a midfoot break, the hindfoot was okay. So again, following similar principles, super construct, You can reconstruct the foot, and this is the patient at 6 months' time, and he's back into his normal custom-made footwear. My last example is, again, these patients, this very commonly, they come into your clinic or to present to A&E with an ankle fracture. Again, how you manage ankle fracture with these patients is a completely different talk. But again, you need to aim to have more fixation. So treating these conservatively usually end up in a disaster, unlike what most people do. So this is a simple fixation that you do generally to any non-neuropathic patient. This is destined to fail, as you'd expect. So it all failed. This all done elsewhere. Colleagues then decided to take the metalwork and fuse it, and again using through screws, which is not enough metalwork for this patient. And as you'd expect, Charcot developed, and the patient had to have the metalwork removed, and then went to another hospital where I had this frame done. Frame did not work. They couldn't control the infection. They put an intramedullary nail, again thinking it's following simple principles. That doesn't work, and that's failed, and the patient came back with an infection, and that's how the foot looked like. And most people at this stage would go with an amputation. Having said that, you can still salvage these limbs. So you take all the metal work out, you do a thorough debridement, you take your bone biopsies, send it to the lab, and put antibiotic loaded beads. If you manage to take samples before, then you can put targeted antibiotics. If not, you put generic ones, and then you adjust your post-op antibiotics according to the samples. And then once you achieved clear bone with no infection, you can wait up to 6 weeks. You monitor inflammatory markers, you take the patient back to theatre, and then you do the reconstruction, and this patient is actually back in shoes. This is the picture after 2 years of the reconstruction. So along with the Professor Kavathapu in King's College, we developed this algorithm. It's published there about how you manage the infected Charcot as a single stage or a 2-stage. And I'll probably stop there for the sake of time. I'm happy to take any questions. Thank you.
Thank you so much, Mr. Vidair. Actually, I have a question personally first. So, you know, the guys in the Middle East is not all the diagnostic tools are available there. So if you can give them your tips and tricks to catch a diabetic foot problem in the clinic, like a patient coming with non-traumatic injury or non-traumatic fracture, tips and tricks with just simple tools to diagnose diabetic foot and not to miss it.
Sure. Well, I tend to disagree a little bit. You don't need any fancy equipment. If you don't have the neurothiometer, that's absolutely fine. 99% of the clinics in the UK don't have them. So you start with a clinical assessment. First of all, you still take the patient temperature. You do all your septic workup. You need to rule out infection first. So if the patient comes in with a classical sepsis, then that's easy to diagnose. But if not, then you look at the foot, you check the pulses. If there is any evidence of gross infection, pus coming out, ulcers, redness, erythema, all that kind of thing, then you manage it the same way we talked about. If it's a swollen foot, a little bit warm, you're not sure whether it's infected or not, you can do bloods. If it has an ESR of higher than 70, CRP of more than 200, then assume it's an infection, you treat it likewise. You can do an X-ray, you can do an MRI scan, which I believe available in most big centers around the world. And then you manage it accordingly, as we talked about. The key thing is to manage the acute stage. If there's an infection, you need to clear the infection. So any infected dead bone has to come out. You need to make sure you're not treating infection blindly. The most common presentation I see patient come to my clinic with is patient had Charcot for a long time, had a bit of an ulcer. They see Dr. One, whether an orthopedic surgeon or not. They were given antibiotics. Infection gets better for a little bit, then they come back again. And on average, I audited my practice, and patients who usually come to me, they've already had at least 15 courses of antibiotics over the last 2 years before coming to see me. By then, you probably developed resistant bugs to antibiotics and make the management even more difficult. So you need to get samples early on. If you don't have Jamshidi needles or difficult needles, that's fine. Just take them to theatre, make a little opening, and then whatever you think the infection is, just take deep tissue biopsies. You need to know what bug you're treating, and accordingly, you can give them the appropriate antibiotics. So I would say you still follow the same principles. You might argue in some areas you don't have the bolts and beams, which is fine. You can use even Synthes 7mm or 8mm screws. And if the audience is interested, we can do another talk about how to the principles of how you reconstruct these foots and and how you plan your surgery, what metalwork you can use, etc. But yeah, the key thing is to control the infection and offload the foot with total contact cast after you've offloaded the infection.
Thank you so much. So another question is about reconstruction. So if a patient has an midfoot and hindfoot Charcot, so do you do them combined, or you start with one before the other?
I do them combined. If there's no infection, or there is an infection that I know what the bug is and I know I can excise it and debride it and close the skin at the same time, then you can do one stage. And yeah, you need to have a stable foot, whether it's midfoot, hindfoot, or combined, and ideally that needs to be done at a single stage. That's the reconstruction, assuming you have no infection. If you think you have an infection that either you don't know the bug or you're not sure whether you can clear it in first stage, then you clear the infection and temporarily stabilize it either with a frame or wires, and then you go back and do the definitive reconstruction later on as a single stage.
Yeah, thank you so much. Thank you so much, Mr. Bidai. It's really, really good talk. And yeah, you know, it's a very, very shaded area in the practice. Diabetic feet is always missed, and the people are really struggling with diagnosis and management in such cases. Thank you so much for being with us today. And yeah, we can arrange another another talk about more about the reconstruction and options of that. Thank you so much.
Thank you.
So we're going a bit higher up now. So speaking about spine. So today we have, in a way, speaking about spine. He's an ST8 trainee in West Midland. And yeah, his interest is mainly in the spine. So please, always.
Hi, good morning, evening, everybody. Let me just share my screen. All right, can everybody see that?
Yeah.
Yeah, perfect. Hello, everybody. Like I said, my name is Awais, one of the spinal registrars. Sorry I missed the start of the talk, I was putting the kids to bed. But just if people, I don't know how interactive it's been, but some people just unmute themselves and just give me an idea of what sort of level we are. We have, I think, junior consultants, registrars. Who do we have around?
Yeah, so the problem, they can't unmute themselves, but if they have any comment or anything to know, so they'll be putting in the chat. So yeah, this is mostly the level as we agreed. It's between
no worries. Perfect. It's good. Right, so what I'm going to do is talk to you guys about let me minimize that. Good. Cauda equina syndrome and spinal stenosis. The main differences between these. So we'll talk about the presentations, their management, how they differ, and how you try and do different things in each of these. So it's cauda equina, how it presents different to lumbar stenosis, whether it be severe lumbar stenosis or mild lumbar stenosis, and cervical stenosis, because you know, they both maybe stenosis, but they present so differently. Okay, so what is actually the cauda equina? I think a lot of people will be able to answer this. So what vertebral level does it start? Around about L1 on average, usually it's about L1, L2. Some patients may have a low-lying conus, so around about L2, L3, and those are a bit more tricky, but that's quite unusual and quite rare. Where does it finish? Well, that's the nerve roots beginning, so it finishes right at the bottom, all the way down to the cervical, so to the sacral nerve roots itself. So what is cauda equina syndrome itself? And how common is cauda equina syndrome? So, as we know, cauda equina syndrome, it's an amalgamation of symptoms and signs that patients will present with. But together with MRI proven compression would be cauda equina syndrome. We'll talk about that in a minute. So how common is it? Surprisingly, so obviously from spinal perspective, you think it's quite common because you see them quite often. But realistically, it's actually about 1 in 65,000 on average. You know, the data suggests between 1 in 3 to 100,000, so about 1 in 60,000. And patients with herniated lumbar discs who already have proven herniated disc, about 2% of those patients will go on to develop cauda equina syndrome. In general, patients with back pain, you only have about less than 1% of those patients will go on to present with Cauda equina syndrome itself. Other epidemiological issues are patients with congenital narrow spinal canals. And these may be patients with, for example, achondroplasia. These patients will have a tight canal, so they're more prone to developing Cauda equina. Commonly, it's L4-5 and L5-S1. Literature will tell you different things. A lot of people will say it's L5-S1 is the most common, but the most evidence points towards L4-5. But either way, you will still see a varied range between these two levels. So these are the sort of things we're talking about. You know, a large disc extrusion over here that you can see, L5-S1. You can see the conus terminates around about L1, 5, 4, 3, 2, 1. So this seems like a normal sort of box standard patient. You'll see some degenerative changes around them, and generally the soft tissue is slightly wider, but this patient is actually not that big, which goes to show that it's not always the obese patients they need to look out for. It's patients young, fit, active as well, but they may have a poor core strength. These are the axial images where you can see the disc protrusion, anterior to posterior. It's a large disc protrusion all the way here. And this here, if I trace it out, will be the Cauda equina sac. Okay, all the nerve roots inside being compressed. And you all may have seen different or varying degrees of compression in the MRI scans, where it's completely blacked out. Some patients will still have fat. Some patients may still even have CSF within the nerve roots and still present with quite significant symptoms. Actually, the presentation, that's the most important factor that you need to be looking at. So they're red flag signs. We may have learned these in medical school, may have forgotten them as well, but it's important to catch every single one of these if a patient presents with them. So commonly, you'll always have some patient will come with back pain. They will have some form of sciatica, some sort of radiculopathy going down one leg or both. Okay, commonly it will be one leg. They may well develop some autosensation, some neurology, some numbness in their foot around a specific dermatome, some weakness around a specific myotome as well. And again, these are things that you may consider, well, this could just be a slip disc, or could this be a partial presentation of Cauda equina syndrome itself? The key things to point out are the urinary and bowel symptoms. Urinary symptoms are probably the most important, they're probably essentially the most prognostic specific. I wouldn't say that they are the best in terms of diagnosing, but if you do have urinary symptoms with proven MRI findings, then these prognostically are quite important because they don't necessarily do very well and doesn't necessarily depend on how quickly you do operate on them. So these are the patients who have incomplete urination, painless urinary retention, which is one of the most important signs. Patients who may have new urgency, new urinary type symptoms of hesitancy, which has been going on for a few days to weeks. Okay. Bowel disturbance, again, fecal incontinence, usually quite a worrying sign, but again, doesn't necessarily definitely mean they have Cauda equina syndrome. There may be other issues at play. And we all may have seen patients who have fecal incontinence, and actually the MRI scan is completely boxed down and normal. So, but the ones with a large disc prolapse and bowel disturbance, they're the ones to also worry about. Again, prognostically, they don't necessarily do too well, irrespective of how quickly you do operate on them. In terms of the saddle anesthesia, that's relatively quite a sensitive sign. Patients who do develop saddle anesthesia, it is a bit more worrying. Loss of erectile dysfunction, loss of sensation during intercourse. Again, these are quite important factors as well. So when you're looking at the presentation, you've got Todd's paper itself suggests breaking it down into different varying degrees of the presentation itself. So you've got Cauda equina suspected. These are the patients who may have grumbling sort of symptoms. They don't have any urinary symptoms. They may have some sciatica. They don't have any bowel symptoms, but they may have suggested some urinary hesitancy, some increased urgency. And again, these are the ones you think possibly. Cauda equina incomplete. And these are the ones who may well develop saddle anesthesia, but urinary and fecal incontinence is not present. They are completely normal from that point of view. The bladder scans will be normal as well. And these are the patients we also even tend to call Cauda equina impending. Okay, that these are the ones you want to watch or be quick to act on, because this is the point where things haven't gone far enough that you cannot reverse anything. And then Cauda equina retention, as you know, are the patients that come in with a painless retention. And you, of course, want to be operating on these guys much quicker, as quickly as possible, within 24 to 48 hours at the latest. But prognostically, they may well not improve their functions, the urinary function. Now, the most important factor is that the MRI scan will not differentiate between these. These are plain and simply for your presentation, your symptoms, and their signs of the examination. Okay, so an MRI scan, you may well have this MRI scan with in a patient who's got either suspected cauda equina, i.e., just grumbling signs, maybe some hesitancy, urgency, a patient who may be impending or incomplete, or a patient who's in full retention. With this same MRI scan, all three patients will present. So management. So early operative intervention is gold standard. It is the most important factor, irrespective of what we talk about the prognostic factors, because you still give them a chance to improve at some point, which they may well not, okay? The British Association of Spine Surgeons, clear recommendation is nothing is to be gained by delaying surgery and should be undertaken at the earliest opportunity. And therefore, you have spine surgeons who say it needs to be done in the middle of the night if it has to be done then. Some will say it can be done in daylight hours. However, there's nothing to be gained by delaying that time. A point of debate is whether you do a microdiscectomy or a laminectomy. Now, I'll talk to you about the difference in the two. And again, this will be good for people who may be sitting exams or looking further into this. Post-operative rehab, so post-operatively, how the patients are doing are going to be dependent on what sort of rehabilitation they're provided with. It, of course, depends on the presenting complaint, essentially, whether they are in CES suspected, impending, or even retention. But rehab is probably the key factor in terms of mobilization and general power to their myotomes if they become weak. And again, in the UK, we refer to spinal injury, especially here in Birmingham. Any patients with any sort of neurological deficit, we will be referring them to spinal injuries unit for rehabilitation. And that includes bladder training, catheterization, teaching self-catheterize, catheter training itself. And some of these patients do improve, but none of them go back to their complete normality, which they had prior to the issue. One of the things to point out with cauda equina is that between these three presentations, the reason why the guidance is to act as soon as possible, even if you have someone with a large disc prolapse and suspected, is there is no predicting factor to see how quickly they will progress from one to the other. They're in retention. You don't know how long they've been in retention in. Patients will report to you, ideally if it's within 12 hours presentation. But again, you don't necessarily know exact timelines of retentions. So laminectomy versus microdiscectomy. Now, when I say laminectomy, for those who may not have a spinal interest, it's a full posterior laminectomy, spinous process and bilateral lamina. You are doing a full pedicle to pedicle decompression, left to right. And anybody who may not have sat the FRCS, if they are looking to sit the FRCS exam, this is your answer. This is a buzzword answer that you will always do a laminectomy, and it should be a pedicle to pedicle decompression. That is the absolute gold standard. With these sort of patients, again, you've got a 5 to 15% risk of recurrent disc. Now, that doesn't mean that they will have cauda equina syndrome again. It just means they're a higher risk of a disc prolapse as the disc has already been violated. Okay? So this is something to always mention to your patients if they are presenting as an emergency, that their risk of recurrence at the same level is relatively high. Again, with a laminectomy, these patients don't do very well from back pain. They may well never have had back pain to begin with. It may have started a few weeks before their cauda equina syndrome. They may well have had only sciatica. However, post-operatively, they will have some element of back pain, which the treatment predominantly would be physiotherapy, core strengthening. Some patients do go on to improve and back to their baseline, but we always warn patients that that is something to always worry about and look out for. High risk of post-op collections. Now, with a laminectomy, as you can imagine, I think there you go. Here's the laminectomy. You're removing the whole lamina and the pedicle and the spinous process, and suddenly you've given yourself a dead space. You have the fascia, which you then clothe. However, between the fascia and the dura, you've got a lot of space for fluid to collect, whether it be hematoma, simple fluid, just post-operative recovery, reactive edema. But again, all this has a risk of getting infected. So that's one of the biggest issues with the big laminectomy. And you also have the risk of destabilization. Depending on how wide your laminectomy is going, you're going pedicle to pedicle, and you are preserving the joints. You may have to undercut some of the joints, but depending on how much of the joint you're taking will risk how much you destabilize the patient. In an emergency setting, it's not necessarily the be-all and end-all. If you do destabilize a patient, they will have a gradual anterolisthesis, a gradual slip, which can be looked at. You can get x-rays and eventually look at fusing them and fixing them. I'll talk about that separately in spinal stenosis and lumbar stenosis, where it is important to look at preoperatively. At this time, it's an emergency. They don't necessarily need to have standing x-rays or anything like that. Now, microdiscectomy, it is proven. It's relatively common that some people will still do a cauda-equina compression using a standard microdiscectomy approach, which would be single-sided laminectomy or a fenestration, moving the dura, moving the nerve root, and removing the extruded disc. The benefits of this, it's a smaller procedure, it's less muscle stripping, it's a unilateral muscle stripping. The back pain rates are not as bad. Again, you've left the midline in situ, so again, the back pain, it will still be present, but nowhere near as bad as full laminectomy. You've got a much smaller, tighter space. A lot of people I've seen do microdiscectomies for cauda-equina syndrome will quote that they get away with more problems, meaning if they do have a bleed, if they do have a hematoma, it's not significant because it's contained. But again, on the flip side, it can be compressive as well. They will say if they have dural tear, then again, it will be contained. And that's definitely more true for the microdiscectomy. If you do have a dural tear and doing a laminectomy, in that dead space, it will continue leaking. It will continue leaking, and they're the patients who will have your post-op complications in terms of the headaches, photophobia, to go into meningitis, photophobia, but generally headaches, low-pressure headaches. But in this group of patients who undergo microdiscectomy only, they do have a dural tear, they tend to do much better. The problems, again, with microdiscectomy is that you haven't decompressed significantly. You may well have left a partial disc, which could be causing compression. There's still other part of the lamina, which could, again, be adding to the compression itself. And medical legally, if the patient were to develop cauda-equina again, or continue having ongoing pain, ongoing numbness, urinary symptoms are hard to say, but you would get a repeat MRI scan, then these sort of patients would be liable to sue, to say you've not had a full decompression. So stenosis. Now, how is that different to cauda-equina compression? So if I go to one of the MRI scans here, you look at this around here, L4-5, and you look at the axials, you go, well, how is that different? Well, you can turn around and say this patient would present to you in a clinic. This is a patient who would not go off suddenly. So lumbar stenosis itself, well, I'll generally mention spinal stenosis, but in specific to lumbar stenosis, it's caused by gradual degenerative changes. And the natural history of it is that you have a patient who will start getting degenerative changes. Their disc will dehydrate, which means the height between the vertebral bodies will start dropping. Once you drop, the facets start becoming unstable. You start getting some shift, very micro movement. That shift, what that ends up doing is causing facet hypertrophy. You get facet hypertrophy and flavum hypertrophy. So that all thickens up. Now, all you can think about that, it's all coming from the posterior side. It's pushing from the back to the front. In cauda-equina, you've got the big disc prolapse from the front pushing up, compressing anterior to posterior, whereas in lumbar stenosis, you have posterior to anterior. One thing to clarify, I forgot to mention earlier, sorry, is that cauda-equina syndrome isn't just lumbar disc protrusion. Most commonly, it's lumbar disc protrusion, but you can get a cauda-equina compression and a syndrome as such from tumor, from collections, or from a fracture. Anything that's compressing the cauda-equina and causing these symptoms, specific symptoms, would be cauda-equina syndrome. But we'll speak in terms of cauda-equina syndrome with a disc prolapse, which is the most common presentation of it all. So, as mentioned, posterior to anterior. You can see over here, the flavum is hypertrophied. Your facets are now wearing out. There's very little fluid and space between the facets here. They're wearing, and therefore they will hypertrophy as well. And all the compression will be coming mainly from posterior. Of course, they will have some element of disc protrusion. But again, if I was to cover up the posterior aspect of it and you saw just that, you'd never think this patient has any sort of symptoms. You think, well, that shouldn't be enough to cause any of the problems. But it's all the posterior work that's causing these symptoms. So how quickly does lumbar stenosis progress? So this isn't something that will happen over days, over weeks, but this is something that gradually happens over months and years. But they will come to a point where we mentioned there at the edge of the cliff. I think it's on one of the other few slides I'll come to. That these patients will have back pain, These patients will have sciatica. They may have bilateral sciatica, or more specifically, spinal claudication. Now, that's the degenerative causes of it. Other causes, listhesis, anterolisthesis. So you can do, it depends on the grade of the listhesis. If you have a grade 1 anterolisthesis, it may well worsen over the years and progress to grade 2, 3, which then eventually will cause stenosis. Tumors itself, understandably so, fractures as well. And genetically, again, achondroplasia. Naturally, they have a very narrow canal itself. They are pedicles, and therefore they have a very small canal, and they're more prone to getting lumbar spine stenosis. We talked about this on the MRI scan, but the general anatomy of it. So the main symptoms of stenosis are patients who will be presenting with symptoms that have been going on for some time. Commonly for lumbar stenosis, the most common presentation is neurogenic claudication. Neurogenic claudication is your symptoms of sciatica, bilateral or unilateral, numbness, tingling, legs feeling like jelly, the longer distance they walk. And some patients will say they have pure pain in their calves and their legs when they're walking a distance. And you suddenly start thinking, okay, well, could this be vascular? Again, when you think about the differences between neurogenic and vascular claudication, first point to think, postural changes. How does posture change it? Well, leaning forward in neurogenic claudication improves their pain, improves their symptoms. So patients will say, well, actually, when they walk a distance, they find that their legs hurt. However, if they walk uphill, because they're leaning forward slightly, it's not as bad, they can walk longer. The classic question that everybody will always answer yes to if they've got true lumbar stenosis is, if you walk around a supermarket with a shopping trolley, can you go around? And they'll say, oh yeah, when I'm leaning across the trolley, I can walk around for half an hour, I can do my whole shopping. But actually, the minute I take the bag and start walking to the car, my legs start hurting. Vascular-wise, you've got pulses, the capillary refill, pulses, warmth, all these things will not be affected in neurogenic claudication. So the edge of the cliff, what I was mentioning. So patients who are quite far ahead in their stenosis, again, they may not have these symptoms of urinary incontinence, fecal incontinence, dribbling, but when they're coming closer and closer to the edge where it's becoming more and more ischemic and getting to the point where the stenosis is tightening more and more, they may all fall off the edge, and then therefore they'll present with urinary incontinence or fecal incontinence. A lot of these patients, if they do, that's again an emergency. You treat them in a similar way as you would cauda equina compression, and you do a laminectomy or decompression. But majority of these patients have ongoing symptoms will present earlier. It doesn't mean you have to do an operation in the next day or two, especially if they don't have urinary symptoms, but you may want to think about how bad the symptoms are, decide the urgency of it. Most important factor when we talk about cervical stenosis is in lumbar stenosis, you only have lower motor neuron signs. So these sort of patients will be areflexic if it's bad enough. Their tones will be normal itself. Their powers may well be reduced as well. Cauda equina in these patients is very rare. Again, the reason why is, as I mentioned, if you think about that, the disc is actually dehydrated, there's less of that disc to extrude. Whereas in a young, fit patient, you've got a much healthier hydrated disc. About 90% of that disc will be hydrated, and therefore protrusion is much more common in those younger patients. So management of lumbar stenosis. Okay, well, conservative, operative. You want to give physio to them? Do you want to do injections? Do you want to refer them to the pain team? All of these are appropriate, and it depends on what point they are in their symptoms and how badly they are being affected. A lot of patients may well find actually that physiotherapy may well help, and it's not something that will 100% decline or progress. There are patients who will get to a point and become static. Okay, and if they say that, oh, well, they have a 100-yard walking distance, and they may be happy with that. They only need to walk 40 yards to get to their day-to-day activities at whatever the age they may be. That's fine. They may be happy to live with it. But you always give them the safety net that if it does progress in terms of urinary bowel symptoms, that's when they need to return. Some patients may say, well, no, it's a 100-yard walking distance before I get the severe pain. My legs start feeling like jelly. I get numbness, tingling in my feet. I can't feel my feet and I have to sit down. And I'm 60 years old. I like to play golf. Again, you start to think, well, is physio going to be really beneficial for this patient? It's not going to reverse their stenosis, is it? Injections, 100% is not going to make them cured. At best, it may improve some of their symptoms for a very short period of time. Injections have a much smaller role to play in these patients with stenosis than they do with someone with sciatica due to a disc protrusion compressing only one side. Okay, injections are great for that, but injections are not very good at all for stenosis. There's even evidence to say that injections may even risk progressing the symptoms because you're actually injecting a volume around the nerve root, around where there's not much space to actually compress it furthermore. The sports study done in 2009, it showed that there's very good outcomes at 4 years. You bear in mind, at 4 years, very good outcomes in surgical patients. Their pains are better, they're walking better. When you come to about 8 years, you're matching the cohort again. Of course, the study did have quite a lot of crossover, but the overall long-term changes were similar, with or without an operation, but patients were much more symptom-free and returned sort of activities for the 4 years compared to the others who just continued struggling the whole way through. The most important factor for lumbar stenosis, these patients have a degenerate spine. They will have an element of back pain. The most important factor to mention to these patients is that it will not fix or cure their back pain. It's not treating their back pain, but it's to treat their leg pain, their walking distance. Now, the reason why I skipped that is because I wanted to mention this fact first. Standing x-rays. If you're in an elective clinic, this is a non-emergency situation. You're in an elective clinic with patients coming to you with lumbar stenosis. You say, yes, you'd be a good operative candidate. We can improve your leg pain. What about my back pain, doc? Well, that's not something that's going to be improved unless there's already instability there. Okay, and that's why you get a standing x-ray in these patients. Because what you want to see is an MRI scan is a supine imaging modality. So with these patients, you may not see anything different. When you stand them up and take an x-ray, you may find a slip. Again, that's orthopathy. These patients may well become unstable. If they have that and you're doing a decompression, the risk of their slip getting worse is much higher. And these sort of patients, you're going on a different management route where you're starting to think, okay, well, do we need to consider doing a fusion procedure? Something like a T-lift, A-lift, X-lift, depending on what it is, but we won't get into that because that's a much more detailed talk separately. So in elective setting, patients with lumbar stenosis, please make sure that they do not have anterolaesthesis. If they do, you need to reconsider the options. So your operative options itself, your midline laminectomy, similar to what we mentioned for an emergency coda-equina decompression. There's a even split in terms of patients, in terms of consultants who will do a midline laminectomy, or people who will do a uni or bilateral fenestrations, which is removing just part of the bone on the side. Here you go, I've got an MRI scan of that. So this is spinous process, lamina, facets. Okay, this is a unilateral fenestration. So you're leaving the lamina in place, and you will see either consultants do both procedures, which would be a full laminectomy. So all of this removed to about here, okay, keeping the joint intact. You've got a good wide decompression, but you can see that actually with a unilateral fenestration, you get a good enough decompression as well. And that's one of the main benefits of it. You've reduced that dead space. Again, the biggest argument is you get away with more complications. If you have a dural tear, it's contained. And contained dural tears, even if they're proven on an MRI scan, is not causing symptoms, you don't necessarily have to do anything. There's a lot of debate whether you do go in and repair, but actually if it's contained, not getting worse, just leave it as pseudomeningocele. The problem with that is you'll see beautiful MRI scans like this, but you equally see MRI scans, I've got an example of it, where there's not enough decompression. There's still compression significant enough to cause their symptoms. And you're looking at revision surgery at that point, which makes it much more complicated as well. The midline laminectomy, it depends on how wide you go with that decompression. If you're starting to take part of the joint, starting to take part of the pars, I haven't got sagittal views, if you're taking part of the pars, then you are developing instability. And those patients will continue having back pain, and they may well need something doing in the future in terms of a fusion procedure. Over-the-top decompression, it's another very well recognized and used technique. It's technically slightly more challenging. What you're going is a unilateral approach, and then going across to decompress the other side of the lamina by only stripping one side of the muscles. It's a good procedure, but the risk profile is slightly higher in terms of dural tear, and you're not able to see the other corner of the dura itself or the nerve root if you are going that far. Yeah. Cervical stenosis, the main differing things between cervical stenosis and lumbar stenosis is the presentation in terms of signs and symptoms. But what is cervical stenosis? Well, just a narrowing compression of the cervical canal, much like the lumbar one. Commonly, it's disc prolapses or degenerative changes that are causing this tightness. In young patients, more common soft disc prolapses. Now, interestingly enough, a lot of these patients do not need an operation, especially if they do not have any significant long track signs. If they have simple radiculopathy on one side of the arm, they have auto sensation, which is not too troublesome, and no weakness, you can leave these patients alone. 90% of these patients, up to 90%, will improve with conservative management at about 3-month mark. So you give them 3 months. If the symptoms are not progressing and not turning into long track signs, which we'll talk about in a minute. Stenosis, again, caused by tumors, fractures, the degenerative changes. I'll show you a couple of scans of those. And again, collections like infections or bleeds post-injury or anything like that. So we're going to talk about cervical myelopathy in this stenosis. What is cervical myelopathy? Well, it's narrowing of the canal whereby spinal cord is therefore being compressed and thus causing long track signs. And long track signs are your upper motor neuron signs itself. Your degenerative cervical myelopathy, so it can be either due to a disc protrusion. So a young 45-year-old patient comes with a large disc protrusion, and they may well have myelopathic changes quite quickly. And we'll talk about the signs in a minute. But more common than not, you will find patients with degenerative changes with stenosis posteriorly, anteriorly, which will then cause the myelopathy or plus or minus signal change. So this is a nice example of patient with degenerative changes. You can see front and back being compressed quite significantly. Over here is just the front. And we can talk about the management options in these sort of patients, whether you go front or the back, and that's very much up for debate, a very interesting debate as well. So your myelopathic signs, your upper motor neuron signs. So classically, these patients are going to come to you with a wide base gait. Why do they have a wide base gait? They start to lose proprioception. The signals going back up to the brain be compressed, and therefore they do not know where their limbs are in space and time. So the reason why they walk with a broad-based gait, is only because to get more stability when they're walking. The classic definition for them is that they say they walk like they're drunk, or someone tells them they're walking like they're drunk, and they tend to stumble and fall over quite often. And that's one of the biggest problems or risk factors in patients with cervical myelopathy is falls. Falls just not because they're going to injure themselves or break other bones, but falls because if they have any sort of further hyperextension sort of injury, they're very, very high risk of developing central cord syndrome. And these are the sort of things you want to advise patients if they want to, if you're planning operative intervention, but it won't be immediate. The most important factor is that upper motor neuron signs below the level of the compression. So at the level of the compression will be low motor neuron signs, because now actually low motor neurons and nerve roots are being impinged. But anything below that, it'll be upper motor neurons that are being impinged. Upper motor neuron signs of spasticity, brisk reflexes, Hoffman's, flicking their index finger and their thumb will flick, and Romberg's closing their eyes, standing and see if they have balance itself. These patients rarely do get urinary symptoms, but it's not impossible. They may well present with some grumbling issues, and it's always important to scan the whole spine to make sure you're not missing the lumbar side as well. But the cervical will always take precedence. So when do you intervene? So you've got your MRI scan, you've got your X-rays. Why are we doing X-rays? Well, depending on someone like this, you're trying to see, okay, well, they've got front and back disease. You want to go front or the back. One of the things you want to make sure you don't want to see patients have is kyphosis. If they have kyphosis, doing a posterior decompression is probably a very bad idea without fixation. We saw patients with developing further kyphosis. So anteriorly, so X-rays to see what their alignment is like, and a CT scan if you're worried that the disc may be calcified or whether they may have an OPLL, ossified PLL cell. And this may be at one level or multi-levels. So the degree of symptoms is deciding when to intervene as well. Patients who are myelopathic and gradually getting worse, feel that their walking is getting worse, becoming more unsteady, these are the ones you want to sort of intervene fairly urgently. It doesn't have to be an emergency, ideally within 2 to 3 weeks, to avoid declining further. It does not improve them. That's what we tell patients. Bonus, yes, a lot of patients we do find have improvement. There is absolutely no guarantee, literature to produce that these patients will go back to a normal gait. If they are already myelopathic, the best you can do for them is to stop them from getting worse. And it's always difficult for patients to comprehend that you're not doing an operation to make them better, but to stop them getting worse, because it's very difficult for patients to see into the future, to see what they're actually avoiding. There are debates on whether to operate on patients who are asymptomatic with stenosis and signal change. Say you have an MRI scan patient with neck pain, some radiculopathy, but no myelopathic features, some arm pain. They have signal change over here. You go, okay, well, Now, do you have to operate on them because they have signal change? It doesn't necessarily mean that they are going to progress to myelopathy itself. A lot of these patients may stagnate, but some patients may take a stepwise progression as well and decline. So again, there's a lot of debate out, which is about intervening in these patients early or waiting until they develop any sort of myelopathic features. Front back or front and back. ACDF, angiodiscectomy infusion, it's the absolute gold standard for these sort of patients. It's very well proven, excellent risk profile. Neck pain is improved significantly in these patients when you're looking at the Osgood Disability Index. Their neurology, it may or may not improve. We'll always tell patients they have numbness or weakness takes longer to improve, but numbness, it may well take about 6 months to start seeing improvement in these patients. But pain is the most important factor. And that's the first thing to point out. When you're doing ACDS for radiculopathy, pain is always going to be the factor that they can improve reliably. If you're doing ACDF for myelopathic changes, it's to reduce the progression. That's the most important take-home point for this. In young patients, the unfortunate issue with ACDS is that they have an up to 20% rate of adjacent level disease. So we do quote our patients 20% if they're less than the age of 45, that they may well require another ACDF at the level above or below in the next 5 to 10 years. Okay, the timeline is variable, but usually it is 20%. Posterior decompression, you get a good decompression. It's usually beneficial if you have posterior compression, sorry. Things like this, because again, you take the disc away from the front, it's not necessarily going to improve the back. Patients who have a large OPLL, which you're not able to get to the front of this individual disc, and do a long decompression posteriorly. Now, the issues with this is patients with slightly kyphotic neck, like this. If you do the posterior decompression of this patient, they're more likely to progress, and ACDF will restore their kyphosis. They do have a higher risk of neurological complications. The evidence out there suggests it's mainly due to reperfusion. Again, it's debatable. No one's really sure why some of these patients develop neurological complications in terms of paralysis, myelopathic, myotomic weakness, or even numbness. And the risk of instability, as I mentioned. So the other option would be fixation with it. And there's a trial going on at the moment in the UK called the Polyfix DCM trial, which is posterior decompression with or without fixation in these sort of type of patients. So this is an example of your ACDF, restoring some kyphosis, screw fixation. And this is an image of posterior decompression without fixation and posterior decompression with fixation. So you are taking lamina, spinous processes, and the lamina itself. There's a huge range of different things you can do. You can do French door, hemilaminectomy, windows. We won't go into the details of that. The most common thing is a posterior cervical laminectomy without fixation. But always keep in mind in terms of stability, whether they need fixing as well or not. I'll end it there, whereby we've spoken about Cauda equina versus stenosis for lumbar spine and cervical spine. Thoracic stenosis, the reason I didn't mention it is because the management is very different. For a thoracic disc prolapse, for example, you're thinking about anterior surgery, not a posterior decompression. One of the biggest things to remember is that for the Cauda equina, it's mobile. When you're doing a lumbar discectomy, you can do it from the posterior aspect because it's mobile. You can move the dura to a side, you can move the nerve roots. In the thoracic spine, to do a discectomy, it is very, very, well, it's not high risk, it's very probable that you will paralyze a patient or cause cord injury because you cannot mobilize a cord at all to get to the disc space, and therefore you need to get from the anterior aspect. But the most important factor, I hope you take away, is the history and examination. Sure, the imaging is important, but these three issues, stenosis versus stenosis or Cauda equina versus lumbar, it's the presentation. It's how they are doing day to day, how they're progressing, and if they're declining significantly, that you need to decide when to intervene. Right. Thank you very much.
Thank you so much. Really, really informative and organized. First quick question, how sensitive is the post-void volume in diagnosing an acute Cauda? Just for the general.
Yeah, so it's a very good question because BAS is now releasing new guidance in terms of post-void volumes. In the last year, there's more evidence to suggest that it's not as significant, it's not as sensitive, but we still use it as a very important factor. We use it as an important factor to gauge how a patient is doing. Because if they are in retention, you will know. If you do a post-void bladder scan and they have 700 mils, there is obviously something wrong there. Okay, whereas patients who have a post-void bladder scan of 100 mils, you're not writing them off. It's more to confirm your diagnosis itself rather than to exclude that, oh, it's post-void bladder scans, 100 mils, I'm sure they don't have Cauda equina syndrome. No, that's incorrect. A post-void bladder scan of 700 to 800 mils, you're a bit worried and trying to prep theatres a bit more urgently.
Yes. Just like a quick summary for the junior doctors who received like such a Cauda equina patient in the emergency. If you give them like the criteria of the patient when they need like their heart to be palpating, if they find such a patient, so age, like the most commonly way of presentation, when they suspect the Cauda equina.
So commonly, it's young patients. If you see a 70 to 80-year-old patient with these sort of symptoms, you're thinking other things in terms of MSCC, you're thinking whether they've gone off the cliff for stenosis. But if you start to think classic Cauda equina compressions, patients usually under the age of 50, it is usually overweight, obese patients. Sciatica, it's a lot of the times, myself and my colleagues have seen it's unilateral sciatica. If bilateral sciatica is a red flag sign, but commonly it's unilateral sciatica. But patients who start complaining of saddle anesthesia, any sort of numbness in saddle region, your ears should prick up and think, okay, these are the patients I really do not want to miss out on. Patients with just simple sciatica, nothing else, you can get a scan the next day. But the ones who have saddle anesthesia and any form of urinary symptoms, especially within 12 hours, those are the ones you want to be getting in very, very early.
Yeah. Your tips and tricks to get like positive data from the PR examination. So, ED comment about, oh, it has like a reduced tone and, all this stuff. So your tips and tricks, like how to get a proper PR examination and what finding are you looking for?
Yeah, so in a PR examination, and again, Bass has mentioned this as well, that PRs are no longer compulsory for referring units to a spinal unit because they're not reliable enough. And why they're not reliable? Because it's a very subjective test. Something that's very objective and very sensitive is perianal sensation to pinprick. So every single patient, even if they refuse a PR, I will convince them to say, at least let me check the perianal sensation without an intrusive internal examination. That is extremely sensitive. It'll give you a lot of information. So PR, the biggest things to look out for is, number one, involuntary squeeze. So when you do put your finger, they have an involuntary swing. Every patient will have an involuntary squeeze unless they're completely lax. Cough reflex. Some patients may not want to squeeze, may not be able to squeeze very well because they're in pain. So they've got tone, but they might not be able to get them to cough. It will cause them a bit of pain, but you can feel the contraction around the sphincter. When you feel a lax anal tone, you will know. It's as simple as that. And there's no other way to describe it, that you will just know when it's a lax anal tone, full stop. But the biggest thing is perianal sensation to pinprick.
Yeah, so in a prostatic patient, so, and overnight, the MRI isn't available everywhere. So in a prostatic patient, when you cannot depend anyway on the urinary symptoms, so your tips and tricks just not to miss these patients.
Okay, so with these ones, if you have any inclination, it doesn't matter if you have no MRI overnight, first thing in the morning. Your tips and tricks are your presentation in terms of numbness, weakness. So they will have specific myotomal weakness, ankle, toes, have a thorough examination of that. Reflexes, again, are not very specific or sensitive. Sensation to pinprick. Light touch sensation is never adequate enough. Always sensation to pinprick. Prostatic patients, of course, they will have these urinary symptoms, which are very difficult to differentiate, but perianally, the sensation should be normal. And again, if perianal sensation is normal overnight, you have time to say, okay, you can have the MRI scan tomorrow morning. Does that make sense? Whereas if you're starting to think perianal, they've got saddle anesthesia, altered perianal sensation, they are prostatic patients, you're not sure about the urinary symptoms, you suddenly got something else to justify yourself to say this could well be a cauda equina compression. Hope that answers the question.
Yeah, thank you so much, mate. So it's really, really informative. It's
No
a very
worries.
hot topic, you know. Yeah, thank you so much. Thank you so much,
No
everyone.
problem.
Yeah, thanks,
Thank
Mr.
you.
Malik and Mr. Budair for being with us today. It was a great day, and I think everyone has got a message from every lecture. Thank you so much again, and have a nice evening.
Take care. Thank you very much. Bye-bye.
Thank you so much. I would like to thank all our guest speakers from the Royal Orthopedic Hospital, Birmingham. Also, many thanks to my dear friend and my dear brother, Dr. Muhammad Hashim from Frimley Park Hospital, for being the sponsor of this day and arranging this fruitful scientific day. And see you after 2 weeks in another day with another tour in another big hospital. Thank you so much and see you. Have a nice evening. Thank you so much.
Bye.
Thank you so much, sir. Assalamu alaikum.